The broadcast is now starting. All attendees are in listen-only mode.
My name is Misty Blevins, Partner Marketing and Communications Manager with the National Rural Health Association, SC. I want to take this opportunity to welcome each of you to today's webinar, Telemedicine Reduces Unnecessary Transfers for Rural Long-Term Care Residents, sponsored by NRHA Platinum Partner AMD Global Telemedicine. I will now turn the presentation over to Carrie Dostie.
Thank you, Misty. I would also like to personally welcome you all to our educational webinar on the use of telemedicine in long-term care facilities. During the presentation today, you will learn how Avera Health and Evangelical Good Samaritan Society successfully use telemedicine to reduce medically unnecessary transfers and hospitalizations for long-term care residents by providing the medical treatment in-house. Before we begin the presentation, just wanted to make a couple notes. All attendees are placed on mute during the webinar. However, we will have a 15-minute question and answer session at the end of the presentation. So feel free to submit any questions you may have through the webinar in the question box located on the right-hand side of your screen, and we will address them at the end. Also, the webinar is being recorded, so a link to the archived webinar will be sent within 24 hours of the webinar in a follow-up email to all the participants. So today, our featured presenters are Sherry Davis, the E-Access Director at Avera Health, and Jackie Nickel, the VP of Development and Operations Delivery Systems at the Evangelical Lutheran Good Samaritan Society. And now I would like to introduce Sherry Davis. Sherry?
Thank you, Carrie, and welcome everyone. I know I speak on behalf of Jackie and I that we were really pleased to be able to present this presentation in Las Vegas at the NRHA conference, and then now very much appreciative to AMD to invite us here to speak with you all today, so thank you very much. Today we're going to talk about what we've been doing with the transfers in our rural health care using telemedicine. When we look at what's happening in our rural settings, not only is it important to look at what we're doing on the urgent care side, but also reducing 30-day readmissions. There's a lot of things prompting us to take a good, long, hard look at this. One of these issues is access to providers. Another thing that we look at are the changes that are coming in CMS reimbursement. There's a lot of changes that will be happening by 2018, particularly around the skilled nursing value-based purchasing program. This program has there's a lot of good resources out there that we're going to point you to at the end of this presentation that will give you a lot of detail. But in broad strokes, this program is designed to, as a cost-saving measures, for Medicare reimbursement rates in skilled nursing facilities with higher rates of preventable readmissions. What it's going to do is it's going to create an incentive pool for high performers, meaning facilities that have low 30-day readmission rates, and may also create penalties for facilities that are low performers or have higher readmission rates. The anticipated cost savings is about $2 billion over 10 years. And what Avera and the partnership that we have with Good Samaritan Society is to really look at, what are the tools and resources that are out there to prevent unnecessary transfers to emergency departments and to reduce the 30-day readmission rate. I would like now to turn it over to my partner here, Jackie Nickel, and let her talk about some real world experiences that we've had with this program. Jackie?
Thank you, Sherry. I'm excited to be here today, and thank you for having me. The ELTC program is perfectly positioned to help advance the triple aim of the Affordable Care Act to improve care, improve outcomes, and lower cost. We typically focus on the lower cost, but I think it's really important, and I get very excited when I have an understanding of how this can impact care and outcomes for our individual residents and patients. I want to tell you the story of Harold. Harold lives in a rural location in North Dakota. There on the right, you see what the rural roads often look like in North Dakota during most of the year. Harold is a 92-year-old man who was admitted to the center a week ago after an exacerbation of congestive heart failure. He has a history of moderate dementia, steroid-dependent COPD, chronic renal insufficiency, and seizure disorder. He became quite confused during his last hospitalization, trying to pull out his Foley catheter and IV and get out of bed without assistance. He had been living in an apartment with his wife, but it was felt that he needed more assistance than she could provide at this time, so he was transferred to the nursing facility. Since coming to the center, Harold has been pleasant and seems to enjoy the social aspects of the center. His appetite is good and he's sleeping well at night. The swelling in his legs has decreased from 3+ to 1+ edema, and he's ambulating to the dining room using a walker and with only mild dyspnea on arrival. However, on Tuesday morning, Harold was not interested in coming to breakfast. He said he was too tired. The aide, Tammy, helped him to the bathroom. He only voided a very small amount and then went back to bed. He seemed tired, but pleasant. When Tammy came back to check on him later in the morning, he was sitting on the edge of his bed. As she approached him, he was irritable and seemed short of breath. He did not want to have anything to eat and said his stomach hurt. She notified the nurse, who came to his room to assess him. The nurse noted that Harold was diaphoretic and appeared uncomfortable. She checked his vital signs and noted that his respiration rate was 30, heart rate 105, blood pressure 140/90, and his O2 sat was at 90%. She noted that his abdomen was distended and tender, his lungs had crackles, and his legs were now swollen at 2+ edema. She called the physician, and the physician ordered a transport to the emergency room. Upon arrival at the emergency room, an order was given for a CT scan, abdominal without contrast, blood work, and a UA. They found over 1,200 cc's in his bladder, noted that he was constipated, CHF exacerbation, and his creatinine was up from baseline 2.1 to 3.3. He became confused upon transferring up to the ward and was trying to leave the hospital. He was given 10 milligrams of Haldol and 1 milligram of Ativan. A Foley catheter was inserted. He was given an enema, 50 cc's of fluid over 4 hours, and 40 milligrams IV Lasix. A day later, he returned home to the nursing home, heavily sedated. What I appreciate about the ELTC program and the partnership we have with Avera, and what Sherry's going to be sharing more with us, is that this does not have to be the story of Harold's care.
Thank you, Jackie. So as we move through the next couple of slides, keep Harold in your mind and think about how this may apply to your service or your facility. What is our e-long-term care vision? Our goal here at the Avera eHome is really to improve healthcare services that is going to impact the resident in a way that will either maintain or improve their health status and ultimately reduce the overall cost of care by reducing those unnecessary emergency room visits and hospitalizations. I will be telling you about our experience that we've had thus far. But the other aspect that we believe is very important is that we want to enhance the quality of life for our elders by providing them that access to providers, advanced care planning, pharmaceutical management support. The picture that Jackie put up with the long road, snow-covered, is not an exaggeration. We get out here into the Midwest, and for a lot of our nursing home facilities, it may be tens of miles, it may be hundreds of miles to local, and I use the word local lightly, clinics and tertiary care centers. So that, to bundle a resident up on a cold, snowy night is very hard on the resident. We'll dive deeper into that in a moment. What is the value of a telemedicine program for long-term care? Well, it's a number of things. Today we're really focusing on the urgent care aspect of it, but what that's going to do is provide immediate access to urgent care services. We want to be able to have a provider see that resident as quickly as possible. It does not take long for a resident to have a moderate illness turn into a major illness. We want to provide that early intervention. Keep things from like a urinary tract infection turning it into a full kidney situation. Decrease transportation costs. In the Midwest, a lot of our transportation relies on local wheelchair services. Maybe even the facility might have access to a van. Not every one of them has that. We also have a lot of volunteer emergency services where the volunteers would be pulled from their regular jobs and asked to jump into that ambulance and transport that patient. We want to reduce those unnecessary ED visits and rehab and hospitalizations, including rehospitalizations. And we're going to deep dive into that in a moment. And then ultimately, again, reduce the risk of advanced debilitation and confusion related to the stress of the acute episode of care. When you take a resident out of their comfortable, known surroundings to them, it causes them a highly increased amount of stress, and we really want to avoid that at all costs. So, looking deeper into early intervention and how does that reduce risk associated with hospitalizations? We know transfers commonly result in complications in older residents. Again, they get out of a care facility that they're very familiar with, people who know them, who they know. It really adds to that level of risk in terms of complications. Hospitals will represent a high-risk environment for the frail and elderly. Confusion, delirium, falls. You can imagine your resident becomes very comfortable with the layout of their room in the nursing facility, what's in the hallways. And if they're in a facility that they're not familiar with, and they get up and use the lavatory like they normally potentially would have at their care center, and now suddenly there's something that they're not expected in their way, they bump into, there's your opportunity for a fall. The resistant infectious organisms, cold and flu season is so hard on our frailest of patients, including, newborns, infants, all the way, when we consider the geriatric population as well. As hard as we try, hospitals are risky places for the geriatric population. And if they go to the hospital and they're not sick, a lot of times they will return back to their care center with a bug, and they'll be sharing that with their other residents. So we really, if we can avoid that, that's what we want to do. Access to quicker intervention can reduce the number of acute episodes in many frail residents. So using tools like Interact, like Stop and Watch, where we can notice the subtle changes, like the nurse aide did for Harold, and can talk with the nurse, talk with the provider, and say, hey, something is up here. Things are not as they are normally for this resident. We can begin the care process sooner and hopefully squelch that exacerbation of symptoms and illness. And then there's many financial and regulatory considerations, the bundled care, the value-based purchasing program. We're going to talk about that in greater detail in a moment. So when we look at hospitalizations, the care-sensitive hospitalizations carry an annual cost of about $2 billion. And what we found in our research is that discharge to a long-term care center is still the biggest and best predictor of readmission. Right now, we believe it's about 1 in 4 residents who are discharged to a long-term care facility are at risk of being rehospitalized. And that equates to about $4.3 billion in annual costs. And so we're wondering, can the use of telemedicine help reduce that instance of emergency room visits, of rehospitalization? and ultimately affect that $3.3 billion number. 15% of our population being geriatric account for 50% of all hospital costs. So there's a real consumption versus total population imbalance that's going on here, and we believe that telemedicine can really have a strong impact on that. So how did we do it here at Avera Health? Well, we're very blessed. We have a dedicated facility with several telemedicine service lines encompassing it. We began our e-long-term care program back in 2012 with the wonderful opportunity with a 3-year, $150,000 a year HRSA grant. We operate in 20 sites throughout the upper Midwest, South Dakota, Minnesota, Nebraska, and Iowa. We have a strong and wonderful partnership with the Good Samaritan Society, and we're very blessed that they actually have their national campus here in Sioux Falls, so we can work very closely with Jackie and her colleagues over there. What also is very critical is the right equipment. When we first started out, we had fixed units that were up on walls, much like what you see at home with your television screen. And that was okay. In most nursing homes, space is a premium. There's not a lot of empty room. We try to eliminate things taking up excessive floor space, so we thought let's put it on the wall. The thing is that a lot of those fixed units ended up in the beauty parlor or a PT room or in a common area that really wasn't conducive for that private one-on-one consultation. And worse yet, it forced the staff to bring the resident to the provider. And we just felt that that wasn't quite hitting the mark. And so what we did is we, for the sites that had wireless, we were able to put mobile carts, put the television and the camera on wheels. And for those that didn't, we helped them get upgraded and put wireless into their system. And here in South Dakota and in the Midwest, it's not unusual to find a lot of facilities made out of cinder block or stone roofs, so it makes wireless challenging. But nevertheless, technology is always improving, and we're able to do that and put the wireless in the vast majority of our facilities. Having that, having this device on a mobile cart has made all the difference in the world. Residents, you know, when you're not feeling well, any movement, you know, even turning a resident can cause them great pain and discomfort. So the preference is to make sure that they're comfortable in their bed. Let's bring the provider to the resident and not put the resident in a wheelchair or try to walk them down to the beauty parlor or the PT room. We also have some diagnostic tools available to us. We have a stethoscope that the nurse, the caregiver on the one end at the facility level can put on a set of earphones, and our provider here on our end puts a set of earphones on as well, and the nurse can move that stethoscope and hear lung, heart, bowel sounds, whatever they need. And then we also have a Sony Handycam that we use. While our Polycom cameras that we use have a zoom-in capability, we also use the Handycam that can really get in and get a real close look, especially at things like wounds. It gives you a better bird's eye view than what you could ever get with the naked eye. Also, a lot of our consultating specialists will use the Handycam. A lot of our dermatology specialists like to pull that up and use that regularly. So what have we experienced? You know, right now we have really, like I said, focused on urgent care calls. And at this point, when I first joined the program about a year and a half ago, our video calls that resulted in an avoided transfer was right around 33%. Good, not great. We had a lot of hurdles to overcome. One was that fixed unit that we needed to get into a mobile device. You know, like anything, change is difficult. We had to work and educate the sites and the staff and also the physicians. that this is a change in how we provide care for residents in nursing homes. And we always emphasize partnership. So one of the main aspects to our program is that we make sure that physicians understand that we are not taking over the primary care role for this resident. We are here as a partner. We're a bridge until they can get in and be seen in your clinic. So adding dedicated staff like myself and our advanced practice providers, geriatric trained nurses, our board certified emergency room visits, we really retooled our workflow, and now we're anywhere between 55 and 65% of our phone calls or video calls result in an avoided transfer. We're very pleased with that, and we think we can do even better. So we're constantly looking at ways to improve our service. Education and support for the nursing services truly has that potential to drive the avoided transfer rate even higher. One of the nice things about our, once you have our service, our system, we offer continuing education classes. Avera is a very large system here in South Dakota. We can broadcast continuing education out over our telemedicine network free of charge to our facilities, and nurses can pick up CEUs and they learn very valuable information regarding wound care or assessment skills, whatever the topic of interest is at the time. And then our goal is to introduce more geriatrician-supported services into that model. That is going to support the local providers in discussions around advanced care planning. So not only that, but we're looking at this cross-functionally. One of the things that we get a lot of feedback about is pharmacy. We want to reduce the use of antibiotics. We want to reduce the chemical restraints that are being used. We need to help residents with their polypharmacy, and so we are bringing on a pharmacist that is specifically trained and understands the work that is needed around a resident with those needs. So a lot of opportunity there. And when we talk about cost savings, I just ran our last numbers. Looking through Q2 of 2014, we're a very conservative group here, pretty typical for the Midwest. And for those transfers, we estimate that those transfers cost about a little over $1,300. And that's the emergency room physician, the cost of the ambulance, et cetera, et cetera. And with the volume that we see right now, just in the first 2 quarters of this year, we have a cost savings we estimate to be about $168,000. So there's lots of potential here for cost savings. And the beauty of it is that it's also the right thing to do for the resident. So what is the impact to the resident and the family? For the resident, that immediate access to urgent care in their home, no matter the time of day, I would hate to have to be that caregiver, the nurse or the CNA that says, I know you're not feeling well, but the clinic doesn't open again until 9 a.m. tomorrow, and we're just going to do whatever we can to get you through. No more of that. Now they can say, no problem, we'll get you the help right away, and they can bring in that camera and talk to a provider immediately in less than 3 minutes, actually. They also remain in a familiar surrounding. I know I've mentioned that a couple times. There is no doubt that the people who know them best know how to provide the best care. In fact, we use SBAR, which is an Interact component, which stands for Situation, Background, Assessment, and Request. And the request is the key thing in there. If the care provider at the facility knows that this patient always responds well with this type of medication, then that's what we want to do. If it's the right thing to do, then we absolutely want to do that. The course of treatment can begin faster. Today, what we see typically happens is that, okay, it doesn't matter if it's a Monday or whatever. A resident becomes ill, says they're not feeling well. The nurse may send a fax in to the local clinic, and that fax might sit there for a while. It might sit there for 5 minutes. It might sit there for 5 hours before the staff at the clinic can pick it up, look through it, look through the resident's chart, talk to the provider, get the order, fax it back, and then have the staff at the nursing home pick that up and begin the work, and then get the pharmacy and get all these places and people in motion. So with this, they can talk to our provider immediately. Though they see the resident, we get the history and the background, and then we can write orders, and that treatment begins literally instantaneously. I mean, it's really just a real expedited workflow. And then it provides the families comfort knowing that their loved one has that immediate access to care. They're not waiting. I have a 5-year-old little girl, and there's nothing worse than having to have her wait when she has an ear infection and she's in pain. It's the same thing for our parents and our grandparents. We really want them to feel better as quickly as possible. And then also access to specialists from the comfort of their care facility. Here in the Midwest, there isn't a nephrologist on every corner, and like I said earlier, specialty services can be tens to hundreds of miles away. And so for a resident who maybe needs to see a nephrologist or an endocrinologist to manage their diabetes, their family member may have to take a day off of work, drive to the care facility, pick their loved one up, and then drive anywhere, up to 4 or 5 hours to get to Sioux Falls or Rapid City or Aberdeen to see that specialist. And so they're taking 4 hours to get to that appointment, and you're going to stop and have lunch and do whatever. And then maybe you're at that appointment for only 20 minutes. And then you got to turn around and drive back that 4 hours. It's a lot to take on for a lot of family members. What our service does is that because we have that camera, we have a large network of specialists that we have partnered with that also have this system in their clinic offices. And so within the clinic, they may have the clinic room A is the patient that they see face-to-face, clinic room B is another face-to-face patient, and then clinic room C is their telemedicine. And at 10:15, they have an appointment with Harold, and Harold now sees his endocrinologist face-to-face as if he were there in Sioux Falls having his appointment. It's marvelous. It saves the resident uncomfortable travel time. It saves family members a lot of time. It also saves the providers a lot of windshield time, and we'll talk about that more in a minute. So the impact of the providers and staff, again, that immediate access to a provider is truly priceless, and that extra set of eyes is oftentimes very helpful. A lot of facilities are using Interact more and more. There's a tool called Stop and Watch. It's to note things like what we saw with Harold and say there's a change. It is not unusual for a lot of our facilities to only have 1 or 2 nurses overnight that are caring for as many as 40 or 45 residents each. And so if a nurse aide hands a Stop and Watch to a nurse and says, something's happening here, and the nurse says, well, okay, this is interesting. I sure would like to have somebody to bounce this off of, but gosh, it's 3 in the morning. What do I do? We are a 24-hour-a-day, 7-day-a-week operation, and so they have that extra set of eyes. They can call us up, and we'll work the problem with them, absolutely. And then it's also very nice because they can call us at 3 in the morning, and it can be for absolutely anything, and they can feel good knowing that we have a provider that's awake and ready to help, and you're not waking him or her up, and they'll be greeting you with a smile. And you won't be waking up the local provider that, it just got off of covering the ED and just worked a long day in the clinic, and now he's upset because you're calling at 3 in the morning about maybe something that is something, or maybe it's not. So the staff can feel real good and real confident about having that assistance. Ease of burden of paperwork, faxes, phone calls. When we're out at sites, the number one thing we hear is that faxing. We're always faxing. And then conversely, at the clinics, the physicians say, Sherry, I get so many faxes from the facility. Can you help us with that? We absolutely can. Our goal is to really try to eliminate as much of that paper shuffle as we possibly can. Phone calls going back and forth. All these things affect workflow, and what we really want to do is improve productivity, make life a little bit easier for staff and for folks that are just constantly running anyway. We can help with that. And then ease the burden of attempting the same-day clinic visit. Our clinics here serve a lot of square miles, and again, there's not a clinic on every corner either. And so to try to get someone in, even my own child, you're lucky if you get a same-day appointment or even a next-day appointment. And especially for the frail and elderly, waiting 2 or 3 days for a clinic appointment sometimes just is not an option. So if we can help alleviate some of that pain, we're happy to do that. When we think about our community provider, we're a rural setting. Our providers wear many, many hats. And not only are they wearing many hats in their hospital or their clinic, and they're also wearing many hats in their community. And so what we can offer them is the coverage and the partnership, especially on nights, weekends, holidays. Even though we're 24 hours a day, 7 days a week, it seems like our volume goes up a lot greater during off-clinic hours. I have a colleague in one of our facilities who says, Sherry, my wife has given up on cooking Thanksgiving dinner because every single time we sit down and to eat the bird, my phone rings and it's the nursing home and is needing assistance. And so if we can provide some work-life balance back to that provider, we absolutely want to do that. Again, we're here. We're ready to help. We also communicate care updates on the resident. So anytime we have an encounter with the facility, with their resident, we send them, via fax or phone call, we send them information on what happened. We notify them that we saw the resident for this reason, this is what we found, this is what we did. So we keep the providers fully apprised on the conditions and interventions that we provided for their resident. Again, partnership is the key. We have a very close relationship with our local primary care providers, and they're very appreciative of the fact that we're there to help, especially in the dark hours of the night and on the weekends and holidays. And the other thing that I'm told is that they really appreciate being kept informed of what's happening with their resident. They cover a lot. They do the clinic, they cover the ED, they have a large number of residents in the nursing home, and it's a lot to ask of them. The other aspect of that is that, in rural health, it's hard to attract healthcare workers. We have had instances where we've done physician or provider recruitment, so I include advanced practice providers in that mix, that have asked if we had telemedicine services, and because we do, these roles are much more attractive to them than maybe other rural facilities that don't. So because they know that they're not on an island, that they have that support. And so that's a big win in our rural areas. And then also, the final point there is that we do provide a consistent treatment protocol. We use best care practices. So no matter who you get, if it's one of our board-certified emergency room physicians or one of our advanced practice providers answering that phone that day, they're going to get the best care possible. The types of telemedicine and equipment that we use every day, it seems like there's just new and exciting things coming out, and we're so appreciative of that. So the telemedicine cart is really an important and the key critical component of that. There's also exam cameras, otoscopes, stethoscopes. AMD has a whole complement of tools and devices that really enhance the experience for the resident and the provider. We want to provide a encounter that is just like the same quality as if you were in your physician's office. And so these types of devices are really critical. So with that, I would like to turn this back over to Jackie so we can hear what happens with Harold.
Thank you, Sherry. Sherry certainly outlined for us the many benefits of the long-term care services. And I want to stress that these services could be available in North Dakota or anywhere. Because they're virtual, they could be provided across the country at low cost. The timely access, the less disruption to your volunteer firefighter, emergency transport people, families, residents, the providers in your community, improve quality. And the benefits of this program certainly do help to advance the triple aim of the Affordable Care Act. But let's look at what could have happened with Harold if his facility had the long-term care services. Do you remember Tammy, his nurse aide, coming to check him that morning? She noted that he was irritable and short of breath, and his condition has changed, so she notified her nurse. The nurse came to his room and assessed him and asked Tammy to go down and get the ELTC cart. They connected with the ELTC hub, and the advanced practitioner began working with the client and the nurse at the facility. They reviewed his history. They noted his lack of a bowel movement over the last few days. They reviewed his change in vital signs. Weight gain of 5 pounds in the last week was noted. An exam was done using the stethoscope to look at lung sounds and bowel sounds, and edema was also noted. Bladder scan was done, and urinary retention was discovered. So the advanced practice provider ordered a suppository, a stool softener, and a straight cath. The nurse at the facility completed these orders. As a result, the patient began feeling much better, had a bowel movement, and continued to feel better, and within an hour or so, he was asking for lunch. A much better outcome for Harold because of the ELTC services. And with that, I'll turn it over to Carrie, who will wrap us up with sharing some resources that are available to you.
Carrie, I think you might be on mute.
Thank you very much, ladies. Sorry about that. Sherry was nice enough to help put together this list of resources that she thought you'd benefit from for telemedicine for long-term care. The first one is Health Resources and Service Administration. There's some open grant opportunities, and we'll send out these links in the follow-up email as well. Also, the Centers for Medicare and Medicaid Services, the Medicare Fee-for-Service Payment for Skilled Nursing Facilities, and the American Healthcare Association. There's some information on the Skilled Nursing Facility Value-Based Purchasing Program. So thank you, Sherry and Jackie, for sharing the details of your telemedicine program and how you achieved such great success with it. In closing, before moving on to our question and answer session, I would like to remind you of the importance of choosing the right telemedicine equipment and technology for your specific application. As Sherry so perfectly said, you want to bring the provider to the resident instead of the resident to the provider. So considering the mobility of the equipment and the environment it will be in is a critical component. So when clinical examinations are involved, it is also important to think about the medical specialties who plan to service, and the level of training that is needed to use this technology. And this will help you define the specific products and technology that you need and eliminate the purchase of equipment that won't get used or technology that does not integrate with your existing infrastructure. AMD Global Telemedicine specializes in helping our customers define the telemedicine products that fit their specific needs. Such products as clinical telemedicine systems and mobile carts, medical devices, equipment, encounter management software. And here in closing, we'll move on to the question and answer session. I know we've already had some questions come through, but as we're going through this, if you have additional questions, again, as a reminder, you can type it into the question box on the right-hand side of your screen. I've also included on the slide, if you want to jot down the email addresses of Sherry, Jackie, and myself in case you have any additional questions. And in the follow-up email, I'll also provide this information as well. And I'll turn it over to Misty if there's any questions.
Thank you very much, ladies, for sharing this important message. Our first question is, who takes calls? Doctors? If so, any particularly specialty? Nurse practitioners, hospitalists, nurses?
Yeah, I'll answer that. This is Sherry. So we really don't have call per se because we are a 24-hour-a-day, 7-day-a-week operation. So we call it a hub. We're a virtual care center on the north side of Sioux Falls, so we're actually off the Avera McKinnon campus. And all we do out here all day, every day, is provide telemedicine. So we have physicians, board-certified emergency room physicians, pharmacists, intensivists, and advanced practice providers that their sole responsibility is to provide care out here. And we have a rotating schedule so that there is coverage 24 hours a day, 7 days a week.
Thank you. I was told we had to be hardwired for the stethoscope to transmit good quality sound. Are you using a hardwired stethoscope? What types can be used?
We are not using a hardwired stethoscope. We use our stethoscope runs through our system, and our system runs on a T1 line, so it's part of that video connection, if you will, and we have good quality. And AMD also has a similar product that I don't believe in. Carrie, you might have to help me with that, but I don't believe it has to be hardwired, or plugged into a wall either.
Correct. Yeah, you're correct on that.
The next question, do all urgent issues go directly to your telemedicine program, or does the physician assigned to the patient need to request the urgent care consult? In other words, how is the patient's primary care physician assigned to the patient at the SNF involved?
Okay, that's a great question. So as part of our implementation process, we have our medical director here for our service. We go out to the providers into their clinics and we explain the program and what the intent is at the skilled nursing facility. So before we even put a camera up in the facility, the physicians are aware of the service. They have the option to say, yeah, use this on my residents, or don't. We've never had a physician say, don't use this, so we're very fortunate with that. And so we work then with the site that says, we say, we really don't, care what you call us for anything, whether it's a hangnail or if it's a high fever, we will see that resident. And so and once we have that video encounter, then we write up a referral letter, just like you would in any other, to go to the emergency department, and there's a note that goes back to the primary care provider about the encounter. We do that as well, and we do that the minute the encounter is complete, so that physician knows immediately that, or when they check their fax machine next, that resident was seen via ELTC.
Thank you. Is there a coordination of electronic health information between the doctor, the patient, EMS, and access to it?
You know, there is not right now. We are so hopeful that someday we will get that pass-through technology into point-click care, into Meditech, into the other EMRs that are out there, because that will really make a difference on the amount of faxing and, you know, the information sharing that kind of have to go back and forth between the facilities. So we have tools that we use to try to streamline that process. It's not perfect by any means, but this is something that we are absolutely striving for in the IT world.
Thank you. Do remote providers need to be credentialed at each SNF they provide consultation to?
Our credentialing is state-based, and so the South Dakota, you know, we don't have to have them credentialed or privileged at the skilled nursing facility. It's really more, are they licensed in that state? And the beauty is the way the Avera Health network is we have physicians and specialists that are licensed in multiple states. And so we are covered in that manner.
Perfect. What is the average size of the nursing homes you're currently working with?
We have in our portfolio right now a facility that has about 35 beds, all the way up to a facility right now that has, I believe, 140 beds. So it's, you know, it doesn't matter large or small, the need remains the same. You know, it's really about providing the best care to the resident and to try to reduce costs at the same time.
Thank you. Your program was started with a HRSA grant, which will conclude in 2015. How will you keep your program going after the HRSA grant runs out to keep the carts and devices under warranty and support maintenance? Most grant programs. Go ahead.
Yeah, I'm sorry. Yeah, that's a great question, and that's something, you know, as part of the HRSA grant, we do write a sustainability program, and we understand that margins are tight in the nursing homes. You know, there's not a lot of extra dollars laying around, and so we're looking at a variety of things. One of those things is, you know, is it a very nominal site fee? The other aspect of that is, you know, we do some, there are codes available through Medicare that we're able to do some billing for those services. These are things that certainly are not going to sustain the program indefinitely, but I will say that for us, we are very blessed that, as I mentioned in the beginning of the conversation, was that we have several telemedicine service lines under this roof, and you know, Avera being mission-based, we do this because it's the right thing to do, and so we continue to look at models of how can we go forward. We also, with the value-based purchasing program, are thinking about, you know, do we get hospitals involved? You know, we're trying to save hospitals money, CMS money. Is there a partnership that we can work out with hospitals or with CMS for support of telemedicine service? And then we also look at other opportunities. We have a CMMI opportunity that are in collaboration with an award that we were just awarded to expand our e-long-term care services. So really, this is kind of the long answer to a short question, but you have to be creative, and you have to look at all of the options and things that are out there, and we have to work together to help, you know, let the payers know, CMS and the private payers know that, and insurance companies, that, listen, telemedicine not only improves patient outcomes, but also saves money. And so a lot of public policy needs to be put in place to continue funding programs like this.
Thank you. You mentioned, go ahead.
This is Jackie, and I would just add to that that at the facility level, the value that we're assessing as we spend more time in the LTC program, but the value proposition for the skilled nursing facility is we can bill $26.40 for each encounter. That sounds fairly minimal, but it is more than we would be provided had we, and the nursing hours to prepare a resident and the paperwork to transfer that resident to a tertiary care facility and then receive them back and readmit them. We feel the cost savings there are fairly substantial.
Thank you. You mentioned briefly some of the hurdles with implementing this program in the homes. I am specifically interested in the change management techniques that were successful with staff, as I have heard that can often be the roadblock with successful implementation.
Oh, that is an absolutely phenomenal question. You know, what we did, you know, a lot of trial and error goes into a lot of things. And the most important thing I feel is really initially getting that engagement and that investment with your long-term care administrator and your director of nursing. And then we roll this out to the staff collaboratively. We make sure not only do they understand what the program is, but why they're doing it. How is it going to affect their productivity and their daily workflow? How is it going to affect the resident? And we have found that, you know, if we communicate with them and give them this information and the tools to do it, and more importantly, emphasize its ease of use, we have had tremendous buy-in from the staff. And really, I think that's made all the difference in the world.
And this is Jackie, and I would add to that. My favorite change management paradigm is very simple, and that's start with why before you get to the how and the what. Mm-hmm. And the whys for this program are extremely compelling. You think about the story of Harold and how his life was impacted, could have been impacted by the use of long-term care services. It's about access, and it's about improving care, improving outcomes, and lowering costs. So I think if we stay focused on a change management paradigm that really stresses why we're doing this, we can overcome some of the hurdles or hesitancy. It's not about technology. Technology is the tool. It's about improving health care for our residents.
Thank you. Who drove or drives the telemedicine initiative? Is it nursing or IT?
Well, I think, you know, the telemedicine initiative, I think it's probably both, but I feel, at least the experience that we've had, and that's really all I can speak to, is that telemedicine is really, especially in a rural setting, it's critical. I mean, a lot of folks in our jurisdiction, in our footprint, wouldn't have access or wouldn't even seek the care of even of specialists if they didn't have that telemedicine capability. So I think it's very clinically driven, and I think on the IT side, you know, using remote connectivity, and you see it everywhere. You see Skype and, you know, all these different technologies, you know, FaceTime with Apple iPhones. You know, people want that instantaneous face-to-face technology, and I think it's in healthcare. It's everywhere. And so, clinically, there's a real strong practical use for it, and on the technical side, it's all about innovation. It's the next thing.
Do you have a psychiatrist available for psych visits and treatment? And also, they want to know if you have a cardiologist.
Yeah, so behavioral health is a huge need. It's a component that, at least in the upper Midwest, we have a behavioral health shortage, I would say. And so through our emergency department, we do have a psychiatrist that will see patients via telemedicine. They're scheduled. It's not on demand, so it's not, you know, if you have a resident having a behavioral health issue, that's one that's more challenging for us because we don't have on demand or we don't have that immediate access to a behavioral health specialist. Those are scheduled. And then a cardiologist, yes, we do. We have a large cardiology practice here at Avera Health that has the telemedicine equipment in their cardiology clinic, and they do see our residents via the camera.
Thank you. How many encounters are you seeing for an average size home per day, per week, etc.?
Yeah, you know, it really varies. I mean, just a lot like you and I seem to feel a little bit better in the summertime months. Things are a little bit slower. And then again, when you get into cold and flu season, it seems like we have more encounters that come through. You know, we'll see anywhere from, we've seen as few as, you know, 1 encounter a day, and as many as 5 or 6. It kind of depends on, you know, hey, has the flu hit yet? You know, is the weather changing? You know, is it a full moon? I think sometimes that happens too. It really varies. And so, you know, we have a lot of different programs here that keep our providers and our staff very busy.
And I think the other variable would be the acuity level of the skilled facility rather than the size of the skilled facility. If they're doing a lot of Medicare care or managed care, their utilization may be higher than a facility that is doing more long-term care.
Good point. Very good point.
Does your technology use cell phones in remote places where internet is not available?
We do not use cell phones at this time.
Do you have credentialing overseas, specifically in Africa and the Middle East?
I'm sorry, can you repeat that?
Credentialing overseas.
Oh,
Africa, Middle East.
Oh, yeah, we are strictly, our footprint right now is in the upper Midwest, so we are not at the international level for services.
Thank you.
I love the caller's innovation mind, though.
I love that, though. Yeah, absolutely.
Okay, does the telemedicine program bill for the services?
We do. There are Medicare codes and some the insurance payer codes that we are able to use for our services. We're using G codes for Medicare, and then the 99 codes for in the private insurance.
Can your system track usage by skilled nursing center? In other words, does it possess analytic abilities?
Yes, we do track utilization by facility. So a couple of things that we track is the chief complaint, the time of day that they called, and again, like I said, we do this all by facility. So chief complaint, the time of day that they called, was it a transfer request or not? Did the resident end up transferring or not? And was it just a phone call? Sometimes they call just because they want that, you know, to bounce something off our nurses or our providers, and so we also track that as well. And going back to the question that was just at hand, it's important to note that when you bill for telemedicine, the patient, the resident has to be seen on the video camera. So we do not bill for telephone calls. We only bill for the residents that are seen on the camera.
How long is the wait to get an appointment with a behavioral specialist?
Unfortunately, I cannot answer that question. I think that will vary even on a day-to-day basis.
Okay.
I'm sorry about that.
Do you schedule the consults in at all, or is it just a point-and-click connection?
Yes, the consults are scheduled, and what we do is much like if you're going to be scheduling an appointment at a clinic, the nursing home will schedule that directly with, for example, the cardiology clinic. So they'll call that cardiologist clinic and say, hey, Mr. Harold needs a cardiology appointment, and they'll say, oh, and he would like to do it via telemedicine, and they'll say, oh, sure, that's no problem. We have one at 4 p.m. today or at 9 a.m. tomorrow morning. How would, you know, what time works best for him? And so they really handle that business to business, if you will.
I would like to thank everyone for taking time to attend this session today. I know that we've received many questions that we weren't able to get to today, so all of those will be done by email in a follow-up. I would like to thank you for participation, and a brief survey will be activated as I end this session, and your feedback is greatly appreciated. Thank you, and have a marvelous day.